Hello, everyone. This is Eva Nolik-Smith with Yoga U Online, and I'm very excited to be here today with Dr. Ginger Garner, who joins us to talk about new insights into the close connection between the three diaphragms of the body and how they can interact to affect the well-being of the whole body. So, Ginger, first of all, big welcome to you.
Thank you. Thank you for having me, Eva. I really appreciate it.
And whenever I work on your bio for these interviews, I always kind of get a kick out of it when I read you up, because you probably are one of the most accomplished people I've met. And I deal with a lot of very accomplished people.
Oh my goodness.
But you have like a doctorate in physical therapy, you're a yoga therapist, you're an author of one of the most thorough books on yoga therapy called Medical Therapeutic Yoga. And you're a mother of three, a singer in a professional band, and you're running for political office. This is the point where I start losing my breath. And also, according to your bio, for the last 25 years, your medical career has been focused on using yoga therapy and as training for healthcare professionals and training healthcare professionals to use yoga for both medical purposes and self-care. And if that means you've been doing that for the last 25 years, it means you must have started when you were 6.
Well, yoga keeps you young, right?
Right.
I just turned 45 this year, and I'll credit yoga and hydration and eating well and plenty of sleep with that.
And a few more secrets, I'm sure. Great. So we're here to talk about the three diaphragms of the body and how they interact to support our health and well-being. So right there, most people are probably going to say, you know what? I thought we only had one diaphragm. What are you talking about?
Yeah, and some argue there's an article out there just to get that off the cuff right out of the gate, and this is in the abstract of the webinars that I'll be teaching for Yoga U in a couple of weeks. That some argue there's 2 more diaphragms, that there's 5 diaphragms. I focus on the main 3 because in affecting change in those 3, we can affect the other 2 as well. So we kind of scoop all those up. And the 3 ones that I'm referring to are laryngeal. Some people call it cervicothoracic. In my book, I just called it a thoracic diaphragm, coming above the respiratory diaphragm, which is next, and then the pelvic diaphragm. And we often think of the importance of the pelvic diaphragm or the respiratory diaphragm, but oftentimes the laryngeal or cervicothoracic diaphragm gets left out, and it wants to be part of the party too. So.
Right. And I think the reason we haven't considered these diaphragms is that the breathing, the respiratory diaphragm is one muscle, but the pelvic floor consists of several muscles, and the thoracic diaphragm consists of several muscles. But you're saying they function as a unit and should be considered a diaphragm because of that.
They do, and you can take any one piece and focus on that. So let's just say someone wanted to affect change in the respiratory diaphragm and work on pranayama or yogic breathing. They can do that and have a measure of success. However, if the other 2 diaphragms, upstream and downstream, aren't being considered, then they're only getting part of the efficacy that they could have. In other words, their program could be far more effective if they were considering both of those. And that's really the thrust of offering this particular webinar, and of spending all my time teaching about it and lecturing about it and digging through the research.
Yeah, and I think you're one of the people who emphasize that these function as a system. They're not like isolated. So could you talk a little bit more about exactly what that means?
Well, they're connected in several ways. The first way is through pressurization. We need to have optimal pressures. We know we can get pelvic congestion. We can get congestion in the cardiopulmonary system. And we can also have congestion and edema just in the vocal folds and the laryngeal area. We want to optimize pressure in each of the diaphragms. For example, if we don't have optimum pressure in the abdominal cavity, intra-abdominal pressure, then we know that the spine can be, I won't say destabilized, because there's many factors that go into stabilization of the spine, but you're not going to get optimal functioning. If I don't have optimal pressure, subglottal pressure here up top, I can't speak. I can't function. And if I don't have optimal pressure and what's called apposition, the shape of the respiratory diaphragm, then you think of it as someone who has COPD, or they've had lifelong asthma, or they even have maybe weight management issues, maybe obesity. The diaphragm can be flattened, and that's going to change pressurization there too. So if they have, they could have breathing issues, which then go on to affect the neuroendocrine system. They can also have hernia issues. If pressurization isn't right in intra-abdominal, intrathoracic, and subglottal pressure, then that can skew the system. That's one reason. Another reason is our favorite wandering cranial nerve, the vagus nerve, connects all three of those pieces. And I guess the most poignant example of that I can give is swallowing being a measure of our most visceral, most rudimentary function. And that if we can't swallow, as in breathing also, then there is no life, there is no breath, we can't survive. We must be able to swallow, our most visceral function. That means voice comes next. But if our voice and the sound it makes and the pressure required to create that voice is non-optimized, then you can be sending constant measures of running from the tiger, fight, flight, or freeze via the vagus, since the vocal folds are innervated by the vagus nerve, of threat. So a constant threat signal to this area, whether it is, I teach an orofacial exam, part of that I'll be going over in the webinar. I teach an orofacial exam. If we constantly have, let's say, exterior, external, or extrinsic tension here, and you may often see that if someone's speaking and they speak a lot with the muscles in the neck, or you see them standing out, those have a direct connection, and some of them neurologically, some of them vascularly, and some of them mechanically, to the vocal folds, yet sending more message of threat. So when I'm working with someone that is in pain or has experienced trauma, and I think many people can check both or at least one of those boxes, that they've experienced those, they've had adverse experiences. I need to be able to measure and identify in some way what their perception of threat is. If they perceive threat, which is then interpreted and expressed as fear, that is sending an adverse message to each of those diaphragms, and I'm not going to get optimal functioning. In fact, through looking at the literature, the most important motor system we have is our emotional motor system, not our voluntary motor system. So if we think about the impact that yoga or therapeutic yoga and that the use of yoga as therapy would have through movement, you begin to realize quickly, well, none of the asana then are that important, even though I use asana every day to rehab rotator cuffs and pelvic floor pain, sexual dysfunction, low back pain, and hip labral tears. I use that every day, and I'm very structured the way I use asana so that it's very therapeutic in nature. But if we don't consider that the diaphragms could be perceiving and be getting sent messages of threat, then the most well-laid, asana plans that I have for someone won't work if I'm not connecting with the emotional motor system. And it gets its information from the brain and the gut.
Yeah. what could you talk a little bit more about what the emotional motor system is?
Well, our emotional motor system is driven by neuroception, and neuroception is the body's ability, the mind and brain's ability to detect risk. Mm-hmm. And everyone has probably heard of Daniel Goleman's phrase, amygdala hijack.
No.
Oh, okay, cool. Amygdala hijack I love this phrase. It's when you have a sudden reaction to something, and the operative word is sudden. And in hindsight, you realize maybe that wasn't the greatest response. And that's called our lower brain response, where something happens and our response is, we'll just call it non-optimal. We know we could have said something better, we could have done something better, because we perceived a threat, we perceived risk. Mm-hmm. And if we're not training our mind and bodies to respond in a way that would facilitate safety, then we will get the emotional motor system cutting off our ability to have our voluntary motor system functioning in a helpful way to us. And I see that in a lot of people who have pain, chronic pain, which is the only thing that I've really seen for 20 years plus years as a therapist, is people in chronic pain, and mostly women in chronic pain, but some men who are also in chronic pain as well, is they begin to move, and some don't even get to the point where they begin to move because they're so fearful of movement. And that impacts overall systemic health, their idea of wellness. And as a therapist, I realized that the most important thing that I can do for someone is make them feel safe and give them a sense of a locus of control or self-efficacy. And anyone who comes to see me, I want them to walk out the door feeling like I can do this, right? And that I have control over it, and that I can trust my therapist. I can trust Ginger, and she's going to do her best in a partnership model, not a finger-wagging dominator model, to get me better. Right. So if I can do that, I'm successful. And that's why the emotional motor system is so important. And the three diaphragms are kind of the whole, royal court, if you will. I mean, sometimes I say the voice is queen in the pelvic floor kingdom, and things like that. Or building a pelvic floor that can sing. Because they're so intimately intertwined.
Yes. So let me recap my understanding of, because you were talking earlier about the link to the vagus nerve and the three diaphragms. So what I took out from that part was that if there is tightness in any of the three diaphragms, it affects the vagus nerve and therefore detracts from our well-being.
It does. So that's the neurological connection. That's all that drives the emotional motor response. And then there's the mechanical connection. So as a physical therapist, that's what I would have been taught to dig into, as a new physical therapist, right? What's the biomechanical reason? Find the mechanics of it. We always want to dig into that, 30 years ago when you're in training. But we know now, yes, that's still important, but it's not the whole kind of ball of wax. But what you'd want to be alert for is abdominal scars, and a lot of people have abdominal scars, low back scars, previous surgeries, C-sections, episiotomies, all of the things that would affect the fascial tension. If the fascial layers cannot glide, and maybe it's dehydration. So I talk to patients about nutrition and hydration. If those layers cannot glide, and if there's scarring, deep scarring on top of that, and we know that 90% of patients who have abdominal surgeries have adhesions. Now, only 10% of those go on to have significant complications like obstructed bowel or things like that. But most people are going to have abdominal adhesions, and that will affect pressurization and the vagus input to the three diaphragms, as well as just the straight up mechanical functioning of them as well.
Very interesting. And you are also saying that the balance between the three diaphragm affects core stability and the health of the core.
It does. Let me give you an example. The two questions when I'm training therapists and doctors and sometimes nurses who are involved in rehab, the two questions that I ask them are this: is the muscle that you're identifying? Let's just see, we're talking about the transversus, since that's such a popular, muscle to focus on. Is the transversus abdominis weak, or is it inhibited? And sometimes if it's getting an emotional motor input that detects threat, meaning the neuroception is off of it, then maybe it's not weak at all. Maybe it's just inhibited. So sometimes a patient will come in, I'll do hands-on work, or sometimes meditation, mantra, pranayama, sometimes asana work too. After I'm done with a single session, when I do my pre-test and post-test, the transversus is actually fine. So it wouldn't have gained any strength in a single session. So it was inhibited in some way. Mm. So that's what I ask, that's just an example of what I'd ask, when I'm training the trainers, training the therapists and training other doctors. The other thing that I was going to say is used to use a surgical example. A patient, and I've had this happen a lot. ACL patients, we could use that. Let's use an ACL reconstruction, a patient that comes in. I remember this particular example of, say, a baseball player. He had his ACL reconstructed. And before, in prehab, he had great quad, hamstring functioning, balance. We did what we were supposed to get him ready for the surgery. He comes in afterwards and they're not functioning anymore. Mm-hmm. So what happens, right? They don't atrophy in like 3 days, right? Right. It's most likely inhibited in some way, and we still don't exactly understand the mechanism of why. But I think it goes back to the emotional motor system. There was a scalpel in that quadricep and across the tendon and in those structures. Right. I don't think the body can take such trauma without kind of digesting that as a threat, as it should be digesting it. So what if the emotional motor system is in charge, in effect? And we're talking about the quad, not necessarily the vocal cords, but I believe that some things do shut down when they experience trauma. And then it's my job to figure out, is it a voluntary motor system issue or is it an emotional motor system issue? Right. And the 3 diaphragms help sort that out. Yeah.
And the 3 diaphragm also affect core strength via the intra-abdominal pressure, or rather core balance, core stability via the intra-abdominal pressure. Could you talk about that?
There's three systems or 3 types of pressure that go into the whole pressure system for the 3 diaphragms. There's, you could say intrapelvic, but we'll call it intra-abdominal pressure, an intrathoracic pressure, and a subglottal pressure that are identified in the literature that contribute to the pressurization of the 3 diaphragms. We also know that there are voluntary motor systems, right? So we've got this whole emotional motor system, we've got the voluntary motor system. The voluntary motor system are the 3 diaphragms themselves. The external and internal makeup of the vocal or laryngeal diaphragm, thoracic diaphragm. You've got the makeup of the respiratory diaphragm, which is a little bit more straightforward. It's the respiratory diaphragm. And then you've got a makeup of the pelvic floor, and that's more complicated, just like up here. And if you look at schematics of them, they look, especially in females, they're rather identical. The pelvic floor looks almost the same as the vocal cords for good reason. The functioning of them can be very similar. So especially when you look at the neuroscience, when you pull back the curtain and you look behind, you're like, wow, they're very, very connected in what they do. So in the pelvic floor, we have something that I call a hip lock in medical therapeutic yoga, which consists of the deep gluteal sling. All of the deep, the superficial gluteals, the glute med, the glute min, all 6 of what we used to call hip external rotators, but we know that 2 of them are actually too short to function in rotating the hip. So they actually help flex and extend the hip in different ways. So when you look at the deep gluteal sling, there's a muscle called the obturator internus, and it feeds through the pelvis and into the pelvic floor. So when you think about the pelvic diaphragm, you would think, oh, it's just the levator ani, it's a kegel, it's a Mula Bandha Ashwani Mudra, but it's more than that. That's why in medical therapeutic yoga, I bring the hip lock into it, because they're intertwined, literally, figuratively, they are synergistic. So I can't really pull the hip lock away from the pelvic floor. So when I teach those, I have to bring all of it together. There's also, so we get kind of layer more things on top of it. When you talk about terms of core stability, there are connections. Obviously, the respiratory diaphragm, the fascia of the core, the actual core itself, the pelvic floor are connected. But when you look at the vocal diaphragm, the other layer you have to build in too is the shoulder complex. Some muscles from the hyoid attach to the shoulder blade. They attach to the sternum. That means if someone comes in with shoulder pain, I'm most likely going to find some dysfunction connected, and I need to treat both of those. So when someone comes into me, as a patient, I need to look at the whole picture. All three diaphragms, which then includes the hip and includes the shoulder, their core, their trunk stability, which is dependent on the pressurization, on the vagus input and tone, on their ability to detect threat, which then brings the emotional motor system and the voluntary motor system together. And each can be equally important, but we know that this function, the voice, the vocal area, the laryngeal diaphragm, is probably the most visceral, most necessary function we have. So if I don't treat this area, then everything downstream is, I don't have the best chance for optimizing outcomes.
Yeah, very interesting. Now, if we turn the discussion to yoga and yoga techniques that affect the three diaphragms, of course, the first thing that one thinks about is the bandhas. So are the bandhas a way of engaging the three diaphragms and help regulate the internal pressure?
They are. I've in my text, in the MTY text, I recalibrate those according to the current scientific literature. What does the current evidence base say about the diaphragms and their functioning? And then I apply that to evolve what we used to do with locks, so they look a little bit different. In Jalandhara Bandha, in chin lock here, we're essentially in the text, and there's lots of graphics that you can pick up the book and look at. We're essentially talking about a cranium C1 function. If people don't have that, I find that they're not able to progress into the most simple things like a bridge or 2-foot posture, that I've got to establish ultimately normal laryngeal function, normal cranium C1 Jalandhara Bandha in the way that I define it before I can progress on. Uddiyana Bandha is focusing on not just the way it was traditionally defined of rectus or just an individual isolation, but I'm looking at Uddiyana Bandha as a unit. So what I do there is put it together with Mula Bandha and Ashtwani Mudra. So all three of those go together to construct something I call TATD breath. That's the short acronym for transversus abdominis assisted thoracodiaphragmatic breath.
Oh,
it's a little bit of a mouthful. That's why I just call it TATD breath. And the other way to identify it is just calling it power breath, because we have a regular gold standard diaphragmatic breath where the diaphragms will descend. Now the vocal diaphragm just stays as a steady state, but the other two diaphragms will descend on the inhale and ascend on the exhale. That's when you're relaxing or you're trying to go to sleep. But if you need to, let's say you're a mom and you've got to lift the 3 bags of the groceries on one side and the car carrier on the other side, I may need to train her to use 75% or 60% TATD breath so that she doesn't leak, that she doesn't have pelvic pain, that maybe that hiatal hernia that she has, or that diastasis rectus abdominis, that DRA that she has, doesn't split or go deeper anymore and cause a prolapse. The bladder or the uterus just deciding that it's going to fall out. I've got to be able to train a measure of those bandhas, and mudras, which is called TATD. That's the next section. So we have Jalandhara Bandha, Uddiyana Bandha, Mula Bandha, Ashwini Mudra, composing TATD breath.
Mm-hmm.
That is very task dependent and very functional in nature. For women, it's going to be trained differently than it would be in men. And then the last two that I include that aren't necessarily traditional bandhas or locks are the shoulder lock that I described and the hip lock that I described. If we can bring all those together functioning and then apply our Hatha yoga practice over the top of it, and that's what MTY is essentially about, is taking the yoga postures, the breath work, the mudras, redefining them and evolving them according to physical therapy, other type of rehabs, and neuroscience, and then emerging with something that saves you time, essentially.
Right.
And will optimize pressurization of the 3 diaphragms. So that's what it all comes down to, really, is something that I'll teach those who sign up for the webinar. I'll teach them something called the nap meditation. If people can nap properly and they can use those locks properly, they can pretty much do anything they want. You know, they can, you know, turn on their spidey sense and climb the side of the building. Not really, but they can do a lot and do it well and not have to, they don't need me then. I mean, my job is to see patients, to get them better and out the door, and where they're independent and they don't necessarily need me anymore, except to come back and progress or whatever it may be. But eventually they should be independent and they should be able to manage that pain, or maybe they even become pain-free. So when I wrote the book and when I teach, my focus is to make people as independent as possible, so they spend the least amount of money possible, and they do it in a very efficient way, so that I don't have to ask them, you know, can you do 1 hour working out a day? No, that's not typically what I have patients do. I'll have them do something for 5 minutes, maybe 3 times a day. So I like to look at rehabilitation and wellness as something that can be done in a short time frame that's realistic for them. And that's what the 3 diaphragm approach really is.
Yeah. And just as a very practical example of that is pelvic floor issues like incontinence and prolapse. And you say that most of the time we consider that an issue of weak pelvic floor muscles, but you're really saying, no, it has to do with the internal pressure and how the balance is between the diaphragm and the pelvic floor, and where you put the pressure when you engage. And so that, I think that's a really important contribution that you are drawing out more clearly than is mostly the case, because usually it's like, oh, if you have pelvic floor issues, go do Kegels. But you have a whole different approach. It's really about creating the balance between the diaphragms and enabling the diaphragms to function as a holistic system rather than individual units.
Exactly. And, you know, the traditional kind of approach that's taught in physical therapy even is, you know, you can either up train the pelvic floor or down train the pelvic floor. Up training is Kegels, you know, down training is pelvic floor relaxation. But the reality is it's far more complicated than that. And part of it is exactly what we've been talking about, is optimizing pressurization, of teaching people how to accurately detect risk and not have an amygdala hijack, of optimizing vagus tone and function, which is layered, and I'll be introducing how to do that. There are some distinct measurable ways of how to do that. And the other piece is our management of stress. You know, sexual dysfunction, for example, I had someone come in with complicated gut dysbiosis, lifelong inflammation, blood in the stool, sexual dysfunction that was rather severe. And she had been told for 14 years, and she was only 28 at the time, 14 years, that it was all up here, that she just needed to relax. She had her first colonoscopy at age 14, and those are high risk procedures. And she had come in with all this long laundry list of things, was desperately wanting to have another child, but couldn't because of all these issues. And it was only about 3 visits. It only took 3 visits in using the tools that I've been talking about here before she was independent and on her own and doing well. And just if you look at it from a policy perspective, the cost savings of
Right.
stress, right, that she
Yeah.
had for 14 years and all of the tests, all of the copays, all of the deductibles, all of the things that she had to do. And then she was saddled with no control, little self-confidence, little self-efficacy, and she had a massive distrust, and rightfully so, of the system that had told her that it was all her problem, that because she was chiefly because she was a woman, it must not exist, and that wasn't a real issue.
Yeah.
So it's part of my, and you can hear me kind of veering off towards policy a little bit, but I think that's a major issue that we have to address. If women, and men want to learn to take control of their health, we need to learn some very basic pieces, and the 3 diaphragms are ones that will take you a long way to know what questions to ask your healthcare provider. Are you getting the right care? Is this a good physical therapist you're actually going to? And then how to use yoga in a way that is far more effective and far more therapeutic if we can just enter in these few pieces of solid science. So
yeah, wonderful. So last question, you already made reference to the course that you were teaching on the 3 diaphragms on Yoga U a couple of times, but give us a brief overview of what you are covering in that course.
Well, we want to identify the specific mechanisms from a neuroendocrine, neurovascular perspective and musculoskeletal perspective of what can drive dysfunction. And then go on to determine if we see this impairment, then what do we actually do? And there are things to do, there are things to avoid, there are some tricks of the trade that I'll show you that are easy, simple ways that anyone can practice that have low risk to them. There are some things you might do that might have higher risk. The things that I'm going to teach are going to be applicable across every single population. It doesn't matter whether you teach kids yoga or whether you or whether you're a practitioner and you see spinal cord injury, right? Exclusively, or geriatrics, or patients with stroke. Anyone can use these techniques because I'm going to draw out pieces of the literature that support these techniques across the lifespan, including children with learning disabilities, like being on the autism spectrum. These techniques are going to work for them too, as well as women's health. The voice really is the telltale sign of health in a person. To me, it's the new biomarker for wellness, including sexual health and health all the way across the lifespan, which moves far past just core structure and health, even though that's where I've spent the bulk of my time, is treating low back pain, hip pain, neck pain. Now I'm treating a lot more vocal issues too. But the chief driver of all of this, vocal complex, all 3 diaphragms, the motor systems that I've discussed, is stress. Is stress.
Right.
We need to be able to change the way people respond to stress, and that will be the underlying component, because in all the research literature that I have reviewed, stress is a driving factor for vocal issues. If a person has vocal issues, I can usually match up what's going on downstream with other impairments in the diaphragm. So that's in kind of short what I'll be going over.
Right.
It's a lot of information packed into one, but you'll walk away with things that you can apply immediately in your classes, or with your students, or with your patients if you are a healthcare provider.
Wonderful. Yeah, and I think, like as with most things in yoga, it sounds like it's another way of learning how to use our body more effectively and address not just specific issues, but really improve our overall well-being. So
it's very biopsychosocially driven, very preventive in nature, but for those with specific diagnoses, it will also help them as well.
Wonderful. Well, Ginger, thank you so much for joining us, and very, very interesting material. And thanks for all the great work you're doing.
Thank you. I love what I do, and I just love every time we get a chance to sit down and talk. I could do this all day.
All right. Well, thanks again, and we very much look forward to the course. Take care.
Thank you. You too. You too.